Hello, everybody. Welcome once again to ScanO Cafe. Today, we have a distinguished guest who is an HIV specialist and a general physician since 14 years. Welcome to our show, Dr. Milind Kulkarni.
Thank you.
We are honored to have you and dive into a journey of how HIV patients suffer from AIDS, and eventually that's also been reflected into oral cavity. And we're going to also talk about a lot of misbeliefs as we were having in the conversation earlier. How do we bust them, and what are the most preventive methodology for these segment of patients so that they can have least consequences and try to have a normal life, right? Before that, Dr. Milind, we want to dive into your journey. Can you please help us understand why did you choose to be an HIV specialist? How has your journey been from the beginning?
So after completion of my MBBS, I was doing my chest medicine post graduation in Ruby Hall Clinic. Then my PG teacher on one day told me that there is a very so much amount of myths and uh, misbeliefs in doctor community as well to treat the HIV positive patients.
Hmm.
So being a chest physician, we have so many HIV patients, those who are having tuberculosis. So we have to cater them on a day-to-day basis. When I was doing my PGs, it was in 2006-7 on that point in time. So my PG teacher told me that why don't you go to the eminent personality in HIV field, which was my PG teacher also Dr. Pujari,
Hmm.
Sanjay Pujari. So I said okay. Then I met him, and then fortunately I got a certificate course in same field, like certificate course in HIV/AIDS medicine. So that was also started in Ruby Hall. So I was the first student to take that admission into that particular line.
Oh, nice.
So since then I have been connected with HIV, and later on after completion of that certificate course successfully, and I joined NARI, National AIDS Research Institute, which is there in Bhosari now, in Pune only. So I was there in for almost 6 years. I was heading one project with USA. So slowly, I was there in HIV field. So my myths and misbeliefs has gone down, and then I started working with the patients. What are their day-to-day problems? How to address their day-to-day activities as well.
Correct.
And what they face is the basic, as far as our community and surrounding is concerned. Everyone is like flooded with the stigma and discrimination, and then you have to exclude those guys from the community. You have to like you can say like wallet takle. They are away from the society, like they have to be treated in isolation or something like that. What we have seen very closely in COVID era, like isolation, and rest of the other things.
कसं वाटते?
Yeah. So, so, so that has a mental impact on them, and they just go get introverted. They don't want to be into the like community in the social. They want like sometimes there are certain people they go antisocial as well. So and when I joined HIV, that point in time, so many patients, those who are having the opportunistic infections. So due to that, they came to the hospital, and then they got detected to be HIV. Then we have to treat first their opportunistic infection, and then we have to them make them comfortable with our counseling, with our treatment as far as HIV part is concerned. We have to address their families, their social standing, even for their, we have to give support to their families as well. So that was a very new field for me, as you can say, like why I came to the HIV field. So being a chest person, I was dealing with the TB in and day in and day out with HIV having. So that point in time, the incidence was pretty much high, and most of the time patient do come with TB and then they get detected with HIV. So it's a, so now the dictum says that whenever you get a patient, today's guidelines says that whenever you get a patient with a TB, you have to screen them for HIV, and whenever you get a patient with HIV, you have to screen them for TB, because the TB is the most opportunistic infection in HIV. Because in HIV you have a immunosuppression, or you can say your immunity gets compromised. That CD4 goes down, virus goes up, and patient become prone, or you can say susceptible for any kind of opportunistic infection. For that matter, if you start from like head to toe, the patient may have loss of hairs, skin infections on the face, and then as your fraternities, as far as dental part is concerned, patient they do get angular cheilitis, then they have some oral candidiasis, oral ulcerations, oral tumors as well, and there are some of the non-Hodgkin's lymphoma which is pretty much common in oral cavity. However, Kaposi's sarcoma is also common, but not in India as such. However, we get sporadic cases of Kaposi's sarcoma as well, but NHL is very common as far as oral cavity and oral tumors are concerned. And the most opportunity infection as far as HIV having a dental problem, or maybe you can say oral problem in a broad spectrum, then the patient they do come with oral candidiasis.
Correct.
So white curdy spots on the mouth, like दह्यासारखे दाणे तोंडामध्ये दिसतात. If you check their oral cavity, you get white spots, curdy white spots.
Correct.
I think you are a dental surgeon, so you are well aware with that. Apart from that is we used to get the questions in HIV how like oral hairy leukoplakia. You can say it's a hallmark of HIV. You can say oral candidiasis ultimately having a problem with the oral cavity, along with that is spreading towards the esophagus as well. So if esophageal candidiasis is a hallmark of HIV, you can say. So the person who is having a oral candidiasis, the person who is having a esophageal candidiasis, or maybe oral hairy leukoplakia, HIV test should be
Positive.
offered. No, it should be offered. Whether it comes positive or not, but most of the times it comes positive
because that's the hallmark
yeah,
test.
that
right?
you can say like that is a leading sign and symptom going towards the exact you can say diagnosis.
Barobar.
So likewise the journey started, and then fortunately I completed my course. Along with that I joined Nari as well, and then I started my own practice. So right now I am working as a chest physician, and especially I proudly put chest and TB physician along with HIV physician.
Right.
And I'm working in Vishrantwadi area.
Doctor, great to know about your journey of, how did you select this field and the kind of patients that you've been seeing, walking us through the hallmark of what could be a confirmed HIV positive, right? These tests and your specialties now, which is chest, TB, and HIV, right?
Thank you.
Over last 14 years, doctor, that you've been in this field, right? Especially the HIV field, have you seen a change of pattern with respect to the demographics of HIV positive patients that comes to you? For example, has it changed from a certain age range, gender range to different now? What do you think would be the reason?
Yeah, it's an interesting question. So previously we used to get old age patients, mostly those who are more than 40 age, or you can say fifth decade of your life or something like that.
Can you tell us the age range that you're looking?
So it's difficult. I mean, as of now, if you say age range, pediatric HIV is now gone almost. So we are not almost, we are seeing hardly one patient in 100 the kids. But yes, after 14, there are so many guys, those who are having HIV positivity after that Tinder app and rest of the other app,
Correct.
dating apps or something like that. So as far as age range, if you want to go ahead, like right from 14, 15 to you can say 50, 60 as well. And there are now very minimal patients, those who are like geriatric. So those who are already positive, now we are catering them as a geriatric HIV positivity, but now we are treating them as a comorbid condition patient. HIV has been taken care already.
Correct.
Taken care means it is not negative or something, but they are well controlled as far as HIV part is concerned. But we are dealing with diabetes, we are dealing with hypertension, we are dealing with cardiac problems, kidney issues, cancers. Those are non-AIDS related. And as far as other comorbidities, rheumatoid arthritis, you can say like, I mean, during the as you are already aware of COVID era as well. So during COVID, there is a lot of surge as far as not HIV positivity, but different kind of comorbidities. So we are getting so many patients with different scenarios as well.
Yeah,
like
types of
not,
demographics.
yeah.
Correct. But it's very In my case, it's very worrisome situation. And I want to cite an example here of one of the conversations, doctor, I was having with an oral pathologist, a senior one. She is the reader in one of the institutes.
Okay.
And her research topic was this change of demographics of HIV positive patients from 50-year plus old male to 16, 17-year old females.
Absolutely.
And when I got into conversation with her, I understood that incidences of all the kind of sexual intimacies, especially oral sex, has increased to a very different level, which is why, and especially females are also more prone to HPV.
Yeah,
Right?
absolutely.
It's a combination which is causing these issues. And also with the advent of all these apps like Tinder and Bumble that we have around, uh, LGBT community being widely accepted, you think somewhere these startups or companies are not educating the end user enough to tell about all the consequences which they are looking? I mean, at the age of 14 and 15, they're just getting started with their lives, right? And they're bombarded with this hard reality. What do you think? Is there educational campaigns happening? I don't know, and I'm really curious to know that.
So it's a, I mean, you are just touching to a different kind of a topic.
Hmm.
It's very difficult, but as you know, like, and as far as India is concerned,
Hmm.
we have not been educated as far as sex education is concerned,
Correct.
right from the age of 8 or something like that. But
Hmm.
now we are heading towards that. The more and more we are getting awareness out of that. So, but the whenever you achieve that puberty or
Hmm.
that age where the secondary sexual character starts
Hmm.
in the male or female, whatever, but that point in time, the sex is going to be, or you can say, physical intimacy, going to be a fascination for everyone.
Hmm.
So, if they are not protected with that particular point of time, so it's going to be, it's like you can say,
Correct.
you can keep your fingers crossed.
Correct.
And if they have multiple times this kind of encounters,
Correct.
say for example oral sex or maybe physical intimacy with multiple partners,
Hmm.
definitely they are going to be at a high risk.
High risk. Hmm.
So you have to set a bar as far as your limits are concerned. You
Correct.
should not cross that limit.
Hmm.
So for that, uh, the education has to be there,
Hmm.
right from your curriculum.
Correct.
Along with that, your parenting plays a big role.
Yes.
Likewise, like mother says to every child, like morning evening आपको ब्रश करना है,
Hmm.
उठने के बाद and सोने के पहले.
Correct.
So as I said, like it's a big
It's a
topic,
big
so we may
topic.
get diverted.
Correct. No, I
So
mean, the reason I
so
touch the education is, I think I want to
so
zoom out a little bit and tell my reason of mentioning that is when we started with the epidemic or an endemic of these problems in our country. Let's start with chicken gunia, right? Or it was malaria and then HIV. And in last 30, 50 years, we are looking at declining these problems, right?
yeah,
Or polio, now polio drops is gone,
absolutely,
etc. So
absolutely.
every disease has its own line,
Course.
and course. And how do we want to control it? Where I want to get it, doctor, is when we started, say, maybe 50 years back, how was the prevalence of HIV versus today? I want to know that it has come down, right? And if it has, by how much percentage? Of course, the trend of demographic has changed
Absolutely, absolutely,
drastically.
absolutely.
But in totality, have we reduced the total number of patients who were earlier positive? Tell us more about
So
from a zoomed out perspective.
yeah, basically for the first time we got a patient in 1983, HIV positive patient in America.
Hmm.
Then we got to know first HIV positive as far as India is concerned in 86. Uh, I think she was a CSW, like commercial sex workers in Chennai, I guess.
Hmm.
Uh, then started with that, there was a big panicky, you can say phobia about that particular field.
Hmm.
And slowly in 1998, we got to know that Zudovin is a drug which is there for treating HIV positive. So since then, 98 to 2004, there is a lot of drugs which came into the market. And from 2004 onwards, National AIDS Control Organization, as you know, like every disease has a epidemic control
Hmm.
as far as our central government or state government is concerned. So National AIDS Control Government Organization came into the picture.
Hmm.
It was a NACP, like National AIDS Control Program.
Hmm.
That has some different phases, like phase 1, phase 2, phase 3.
Hmm.
So then that point in time we were having a big incidence.
Hmm.
Like you can say 2004, before we have almost more than you can say 50 lakhs patients as far as India is concerned.
Correct.
Fine. So, but with the comprehensive and enhanced surveillance, uh, in 2006, their first prevalence says that it was higher as far as India is concerned. But in 2006 onwards, when we have done a sentinel surveillance, like in the initially I told you that if someone has a TB, we have to screen from the HIV. If someone is getting that lady is pregnant, we have to check her for the triple H, like HIV, HBCG, and HCV. Similarly, those who are having STI, sexually transmitted infections, then we have to check them ultimately for the HIV as well, or vice versa. If someone is getting HIV, so we have to check for the other you can say co-infections, you can say, like the person who is having HIV might be having hepatitis B, might be having syphilis, or you can say other chlamydia, gonorrhea, and as you rightly mentioned, HPV as well. So HPV is also common as far as HIV positives are concerned, especially those who are having a homosexuality. So likewise, in 2006, we came to know that there are going to be there were almost 35 lakhs patients in our India. So with the enhanced surveillance, increase in the ART centers all over Maharashtra, all over India. So I think we are having more than 500 ART centers, which gives antiretroviral therapy, which is anti-HIV treatment to HIV positive individuals free of cost. So with the advent of those ART, along with the counseling and stigma and discrimination, reduction of the stigma and discrimination, we come a long way now. So now it's a promising journey, you can say, since 1983, 1986, as far as Indian part is concerned. Now it's 2025. So it's more than, I think, 30 years. So in these 3 to 4 decades, we have achieved we came a long way, right from one single pill, right from multiple pills, we are coming to single pill. Now we are coming with single pill with a triple drug combination. Now we are here with double dose only. So, and the size of the pill is small, less than your button as well. So we came long way. Right now, if you want to tell me, I mean, I have to tell you the prevalence, or you can say incidence. As of now, roughly 24 lakhs patients are there as far as Indian population is concerned, and with that, males are more than the females. And as far as Maharashtra is concerned, Maharashtra said is a top in HIV.
Is it out of all the states in India? Maharashtra is the first one.
Previously it was on fourth. Now it is as good as first only.
So which are the first top three?
You can say first Maharashtra, Karnataka, Andhra Pradesh.
This area, this region. Any particular reasons? There's nothing, no way of.
No, it's a again it's again a sexuality. Then you can say a behavior of the patient, people, and or you can say concentrated
in that
epidemiology, epidemics, you can say.
Correct.
So right now also we are facing that GBS in that particular area of Pune, like Sinhagad, and similarly we used to get so many patients from Karnataka initially when I was joined HIV field. Now we have these metro cities all over Maharashtra and all over India as well. So you get a mixed picture everywhere.
Correct.
So
right. So we have an roughly an estimate of 24 to 25 lakhs people who are positive, and they are controlled in a way that we are looking at.
So for that, WHO has set a target for us. Like initially it was 90-90-90. So 90% of the population should be diagnosed with HIV. Out of that 90% population, 90% should be on the treatment. And out of that treatment, those who are 90% on treatment should be suppressed. Those numbers should be 90%. So 90-99. Now that bar has set us for us is 95-95-95. So right now, as far as India is concerned, we have almost diagnosed 86% of the patients with HIV. Out of that, 77 patients are on treatment. 77% of the patient.
Correct.
Out of that 86, and out of that 77, 72% of the patients are suppressed as far as their HIV part is concerned.
That's good, but we are increasing towards that 95.
So we have to set that, we have to achieve that target. As of now, it appears little difficult, but I'm sure with more awareness and percolating to the grassroots level, and maybe adhering to the treatment, giving treatment to each and everyone, and addressing their issues as far as social
Correct.
stigma and discrimination are concerned.
Absolutely.
And of course, reducing the promiscuous behavior, or you can say high risk behavior of the patients.
Correct.
Or people.
Correct.
We can achieve that.
Right.
I mean, when I joined this field in 2006-7, there were patients when we used to touch them. Next day, the relative comes and they just praise us.
Nah.
Now, and facing to doctor is a bit difficult for them. That they are getting discomfort. They have so much amount of discomfort. Doctor, they cannot utter a word of. ते म्हणायचे की मला तो आजार झालाय. So likewise you can say.
Correct.
They have that much amount of stigma
towards
what will be the
what will society
next scenario, like
what will happen.
What will happen later. But now, as you said, with the dating apps and everything, and the internet and social media, 16 years old guy comes to me, yes doctor, I have some you can say unprotected sex, I want to go for a treatment immediately after that. So I used to get shocked.
Yeah.
They just come and they just tell that I had this kind of a problem and I want to go for this. Because everything is there on the
internet. Correct.
So this is a change, you can say.
Yeah, it's a huge behavioral change.
Absolutely.
Huge change.
And they just come up front to in your cabin and they say, so I have to discuss. Now I'm having this kind of a problem.
Now I'm positive and tell me what to do.
Yeah, absolutely.
Do they have any kind of regret, or do they understand the depth of consequences, or
so it's very difficult to some of them are absolutely depressed. They just want to go for a, they can say, you can say suicide or something like that.
They might have suicide
but
thoughts.
There are certain pockets, patients, those who are coming particularly from the pockets, they are bindas. कुछ नहीं होगा सर, वो गोली लेना है ना सर, चलेगा मैं ले लूंगा, no problem.
It's very weird. Anyway, I mean, before jumping to the next topic of having oral cavity as first of the diagnostic lines for HIV, I just want to cover one very interesting pointer that you mentioned, doctor. 87% of them have been diagnosed out of 100% which are positive. Is that right? So when you were telling me 95, 95, 95, you mentioned 95 should be diagnosed, and then 95 should be on treatment, and 95 should be suppressed. You mentioned currently 87% have been diagnosed.
Yes.
Which means 13% who are positive are yet not diagnosed.
Yeah. They are not aware about that.
That they have the
they might be having some sort of a problem, but they are I don't know what are the hurdles for them, or what are the challenges for them to come to a primary care physician, or you can say to the medical fraternity. Whichever could be the faculty, you can say.
Correct.
Could be.
It's very interesting.
So that's where we have to strengthen our social services.
Correct.
To make the awareness. And I mean, social media has a big impact.
Right.
Like when I joined Balbir Pasha ko AIDS hoga kya, that was a headline which started in Mumbai. So with that, everyone was thinking about that. But in our family, so looking towards that particular campaign is a bit different. But nowadays, I mean, you can say, like as far as STI is a concern, then HIV is concerned. So with the advent of, I mean, now I think after you can say big epidemic, you can say, it has been to certain extent, it has made compulsory that everyone should be taught about in medical school as well.
Correct.
As far as HIV is concerned, right. How it is, what is HIV, what is meant by AIDS, how it gets propagated or spread, and what are the precautions to be taken, and if someone comes positive, what are the things to be done, correct. How you have to link them into the management services, you can say. Correct.
Yeah. So this is very interesting. Of 13% who have not been diagnosed yet but who are positive, this is the next element that we are jumping to, is are there any precautionary self-screening guidelines which we can give it to audience today? Of course, at ScanO, we are building where soft tissue analysis would be done, and they would know that if they need to then visit an HIV specialist, or even to begin with and oral surgeon for the basic guidelines, and then he would or she would be referred. But initially, Are there certain ailments that a person himself or herself can look for? Just like today, we have very clear cut screening guidelines for breast cancer, and they can self screen themselves.
Absolutely.
Similarly, would you like to tell our
Yeah,
audience on
definitely. I
that?
mean, the one who is having tuberculosis ultimately gets screened at the TB
Hmm.
center. Ultimately, they have to go for a HIV testing. However, those who are having, say, for example, as we have discussed about the LGBT community,
Hmm.
along with if someone had an unprotected intimacy or something, they can go for a oral screening as well. There are oral kind of a testing, screening test for HIV as well. Like we had some sort of a testing beds, home-based kits which are available for the COVID. Like we used to take a swab, we have to put that into the kit, and whether it is positive or negative, that red line comes or something, like pregnancy test.
Correct.
So similar kind of a test is available as far as oral screening of HIV.
HIV.
So we have to take a swab out of that oral cavity, and then you have to check it for the HIV screening. Of course, that is not a perfect diagnosis. Once if you are there positive on the screening, you have to confirm it with the blood test only.
Hmm.
So if you say like pricking something is an invasive thing, yes, there is a oral test which is available with me as in many of the centers as well.
Hmm.
There are certain projects from the government of India as well. They are trying to promote that.
Hmm.
However, a lot of awareness has to be made for that.
Correct.
So let's hope for the best. And those like NGOs, those who work for the LGBT community or maybe particular kind of patients or HIV positive individuals, they used to direct those patients to us.
Hmm.
And if someone has a you can say an encounter, accidental encounter, so they can go for a PEP, which is called as a post exposure prophylaxis. It has to be taken within first 72 hours of that exposure.
Hmm.
So with that they can halt the possible
Spread
transmission
of
of
the
HIV, or you
virus.
can say if they feel that they are having a potentially risky kind of exposure, they can stop at then and there only.
Hmm. Correct.
So this is the advent of PEP, which is called as a post-exposure prophylaxis. Now, coming to other way around, you can proactively start with the treatment that is called the PrEP, pre-exposure prophylaxis.
Hmm.
Like we had discussed about the dating apps and everywhere.
Correct.
So on Saturday, Sunday they are full. So you can start your PrEP, which is called as a pre-exposure prophylaxis for HIV. 7 days before, 14 days before only.
Mm-hmm.
If you feel that if you anticipate a sexual encounter or physical intimacy, say for example on Saturday, Sunday, so you start that treatment earlier only. That is called as a pre-exposure. However, that needs to be taken care with the like advice of the physician, expert physician, and ideally, I would recommend daily PrEP.
Daily
If
PrEP.
someone is having a
High risk
high risk
behavior.
behavior or maybe uh, uh, they are indulged in those kind of activities.
Correct. Mm-hmm.
Knowingly, unknowingly.
Correct. So these people definitely needs to go for PrEP as you mentioned,
and PEP as well.
and PEP as well, and they need to take the swab and they need to check for them regularly. Are there any signs and symptoms of, for example, the kind of boils or ulcers that they would get on their private parts, or maybe look into oral cavity if there has been an ulcer for a while, or oral candidiasis as you
Absolutely.
mentioned?
So there are going to be a certain terminologies in medical field, like
Yes.
non-healing, non-resolving pneumonia, non-healing ulcer.
Hmm.
So those needs to be addressed. If you have a non-healing ulcer in your tongue, on your or maybe in the oral cavity, you have to visit to an oral surgeon or maybe a dental surgeon. They will definitely advise them to go for maybe a swab or you can say biopsy or something, and then ultimately they can check it for the diagnosis purpose. However, with that kind of a patient who is coming, those can be subjected for a screening of HIV. So with this, you have to deal with the HIV positive individuals if they are going to be HIV positive, or at least you have to screen them, or at least you care that that kind of a scenario can be taken as an opportunity to make them aware that this could be HIV, this could be something else, it could be a cancer or maybe kind of oral pathology or something.
Correct. Very
So
interesting.
I urge every medical fraternity to take the opportunity to screen each and everyone for HIV.
Correct. It's an absolute
So I
must.
think I heard when I was in France, then I have seen that have you tested for HIV? Yes or no?
Hmm.
So that question has to be asked as far as this younger population is concerned.
Correct.
Everyone has to be there, and those who are sexually active.
Correct. Yeah. And needs to be a routine thing. As we make these conversations, non-taboo or unheard of, it will become easier for everybody to talk about it regularly, screen for it. And again, your mouth is the gateway to your body. So some of the signs which doctor mentioned, which are seen by dental surgeons or oral surgeons, but definitely the symptoms could be checked by you through this self-screening methodology. Coming to the third section, doctor, when a patient comes to you, right, you of course see for the lesions in the oral cavity. Where all do you see the lesions for? I mean, what are the typical steps of diagnosing them and giving them as an HIV positive patient? What all steps are involved? And later we will be talking about who are already positive, about all the things that we do for them.
Yeah. So whenever any patient comes to me, say for example, he has not disclosed his status or he is not aware about his status.
Hmm.
So first and foremost thing I have to do is I just check them for the oral cavity as well. So as you know, like you are also a dental surgeon, so oral cavity gives you almost you can say 40 to 50% of the you can say preliminary diagnosis you can say,
Correct.
or it can lead you towards that particular diagnosis. So for anemia, you have to check oral cavity. For dental caries, you have to check oral cavity. As far as HIV is concerned, you have to check for the oral candidiasis or maybe oral hairy leukoplakia, angular cheilitis, or any kind of oral tumor. If someone is having some problem with the voice, you have to check for vocal cords. So maybe ENT surgeon come into play. And if I am a chest patient, I just put a battery or you can take torch in the like light in the oral cavity, so that I should be aware of everything, like whether patient is having a tonsillitis, whether patient is having a curdy white spots of oral candidiasis, or maybe some sort of other oral pathology, or maybe a non-healing ulcer, or maybe they might be having a wisdom tooth which is creating a problem for them. And with that removal point of view, they visit to a dental surgeon, that they came to know to they are HIV positive. Because I'm sure all dental surgeons they go for a triple H testing. Like
Yes.
triple H means HIV, HBsAg, and HCV before handling that person for any kind of a dental procedure or surgery. So this is the first and foremost thing. Then later on, as far as HIV signs and symptoms are concerned, patient themselves gives a history that they have that herpes zoster previously, long back, maybe 2 years back, 3 years back, or 10 years back, and they might be having a high risk behavior. They might be having multiple partners. They have a second marriage, third marriage, or blah blah, and then they might be having some skin lesions as well. Uh, you can say not a known, like the person is having a repeated kind of bouts of fever, unexplained weight loss. Then they might be having a diarrhea which is not stopped by the treatment as well, which is lasting long for 8 days or something, which is called as a cryptosporidal diarrhea, which doesn't control gets controlled immediately. And they might be having some sort of a gastritis, or you can say not able to eat or deglutate properly. So once the gastroenterologist put that gastroscope in the esophagus, he used to come diagnose with the esophageal candidiasis. So with this, they have to go for a screening, as well as this esophageal candidiasis, or as I said, oral candidiasis, or maybe oral hairy leukoplakia. These are self-explanatory that you have to check that patient for the HIV testing. So as I said, like symptoms directed towards the diagnosis.
Correct.
Of course, we have to work on that only. Basically,
Yes.
everyone, anyone, a patient with a single day of a fever also comes to with towards us, or a cough. We have to screen them for TB. We have to screen them for pneumonia. We have to screen them for viral pneumonia. And recently, we had COVID, then dengue, malaria, leptospirosis, H1N1. So all these things to be addressed, and of course, as you said, like they are little bit, we can say, what you can say, like not comfortable or apprehensive telling about their problems with the genital area as well. So if you make them comfortable first, you can have a discussion one to one. They will come to know, then you will come to know that they might be having some urinary discharge, or maybe papules, or maybe lesions on the genital area likewise.
Right. And that's how it leads to the final confirmed
diagnosis.
diagnosis.
But generally, as I am working in Pune,
Hmm.
so it's a, you can say, a metro city.
Hmm.
So most of the patients, they are already diagnosed,
Hmm.
and they are coming to me as a tertiary care center, or you can say expert opinion and treatment.
Right.
So yeah, but I used to do all these things when I was in as a resident and
Right.
PG, and when I started my practice as well.
Very interesting. Thanks for sharing that, doctor. This has been an amazing discussion so far, doctor. I mean, we've understood so much as an audience, as a patient, what all you should be aware of, not indulge in, even if you have high risk behavior, what all things you should be taking care of. Next section, doctor, can you talk something about occupational hazards of how can specialists and dental surgeons in general can take care so that they don't get the virus?
Yeah, absolutely. And this is a big issue as far as your medical fraternity, even dental area community is also concerned. So I used to get a lot many calls even in the midnight as well. So doctor, I had a needle prick. So now I was doing some sort of a procedure and I got a prick. Recently, I had one patient who is HIV positive, and she was going for a surgery. Like fibroid was there, and she was going for a hysterectomy. Then gynecologist was operating on her, and the anesthetist, somehow she came into the picture and she got a splash of that liquid on her eyes and on her face, you can see. However, she was already she was already with the PPE, which is called as the personal protective equipment. But still, she has a that, you can say, क्या बोलते
She
हैं
got
उसको?
freaked out.
She got freaked out,
Yeah.
like
What now? What?
as if I'm, because she is married, she has a kid, and she has a husband, so she was like panic
Yes.
in all others health status. So immediately once they completed that procedure, I got a call, and when I was heading towards my clinic, and I went back, I take a U-turn, and I took the my car to the hospital. And first and foremost, I made them comfortable. I have counseled them, nothing is going to be there. So similarly, I am taking this today's discussion as an opportunity to aware each and every person who is indulged with the procedures, whether it could be a dental surgery, whether it could be a surgery of the medical fraternity like appendicitis, hysterectomy, or any kind of a procedure as well. Even pleural tapping is also a simple kind of a procedure, but you can encounter with the needle stick injury. So that is the most commonest, you can say, in other way around, you can say occupational hazard.
Correct.
As we are dealing with the medical fraternity. So this is not for the doctors only. This is for the ayabai, this is for nurses, helping staff, and everyone. So if you got a needle stick injury, don't get panic. Nothing will go wrong. You have a 72 hours to go for a treatment, which is called as a PEP. However, you have to screen that particular source, whether that source is positive or negative. If he is positive, then you have to go for a PEP. If he is negative, then you have to go into the details of the sexual history or the high risk behavior of that particular patient. And on the day 0 only, you can say, on day 0, you have to order screening test of HIV, hepatitis B, and SC. If HIV comes negative, fair enough, but again you have to ask them for a detailed history as far as their high risk behavior is concerned. So it could be a window period or something. So if you are sure that he is not the person is not, source person is not having any kind of a high risk behavior, you are done.
Correct.
No need to go for a PEP. But if you are in a dilemma,
go for PEP.
Go for PEP, but that too within first 72 hours of the. Now the NABH guidelines says that you have to keep a first dose of PEP, which is called as a post-exposure, available in the ER, or you can say casualty of that particular hospital.
Correct.
If you're doing a procedure in a institute or any hospital,
yes,
small scale hospital as well,
even clinics, right?
Yeah, even in the clinics,
small clinics.
Yeah, absolutely. Yeah. So that can be taken immediately, and then later on you can go for a rest of the other thing, because getting that particular medicine immediately is a crux. You can say ideally PEP has to be taken within first 2 hours of the exposure. Nevertheless, 24 hours, minimum 48 hours, max to max before 72 hours. Beyond 72 hours, there is no role of PEP.
And does taking PEP within 72 hours and 48 and 24, as it mentioned, best is 2 hours, guarantees no spread of virus?
Technically speaking, yes.
Hmm.
Of course, it depends upon the source
Hmm.
and how you got a exposure. If you are dealing with a, say for example, arterial blood gases, you have to put that wide bore needle into the artery of the patient, and on top of that patient is positive, and same artery you get a prick, then you are at a high risk.
High risk, correct.
So within first 2 hours or maybe first 24 hours, you have to go for a treatment as soon as possible.
Correct. So how, which source?
Yeah,
And
it
also
is.
would
It
be
depends upon
dependent.
the where you are working,
Correct.
which part of the
Correct.
patient's
Yes.
area, or you can say a source patient, you can
Right.
say, whether he's positive or negative. And then arterial, wide bore needle, scalpel, small needles, nothing.
Not a big problem.
Because it doesn't have a bore, it doesn't harbor the amount of blood.
Correct. Right. Viral load also would be
Absolutely.
a major concern.
Again,
right?
I mean, you have said rightly that patients viral load has a big role to play. There are certain people, I mean, couples, I do get those who are, one is positive, one is negative. They have their own baby as well, but the wife is also negative and the baby is also negative, but the husband is positive, they are on the treatment. So it depends upon the sexual encounters along with the viral load of that particular patient.
Yeah, depends upon which part of body you are dealing. Since mostly our doctors are dental surgeons in the podcast, is there something more you want to share for a dentist? I will tell you why, doctor. We've been doing a lot of camps, right? Screening drive camps for HIV confirmed positive patients, and I see a lot of dental surgeons freaking out that they don't want to treat them.
Absolutely, I am facing day in and day out.
Right.
Because as you said rightly, I have recently in the last week only I got one patient. He has to remove that particular carious tooth or something, and then he went to that doctor. He has not disclosed his status, but he came with that his prescription. So I took this opportunity. I personally rang him up, that particular doctor, that so and so patient you have seen, and he is my patient. He is already HIV positive. He is on antiretroviral therapy. He is virally suppressed, and yes, you can go definitely for the treatment. So he said, yes, I do treat. But previously, I mean, there are certain patients, those who are, you can say, not like having a myths or misbeliefs or maybe apprehensive as far as HIV part patients are treating. No, there are so many doctors they are treating, but it is interprofessional relationship. You can say you can build up this as a opportunity to make them aware that my patient is coming to you for so and so reason, and you have to do so and so procedure. So be aware of that. However, even if I don't tell them, in our medical fraternity, you also know everyone has to follow the universal health precautions.
Correct.
So you have to use gloves, mask, maybe specs or maybe cap or maybe gown or whatever like that. It is called as a personal protective equipment, and you have to be focused in that particular you can say procedure. Multiple injection has to be given as far as dental surgery and oral procedures are concerned, and you have to give anesthesia as well multiple times. So you have to be a little bit cautious about it. That I am dealing with a HIV positive patient. I have to be
more cautious. Yeah.
So it's some sort of a scene safety, you can say.
Scene safety, correct.
You have to make yourself first safe, and then treat the
patient. In these patients, right, which are confirmed, and treatments like extractions, where we are anticipating more blood pool.
Absolutely.
Versus say small fillings.
Instead
or
of that blood pool, you can say droplets of the blood, you can say, while drilling or maybe doing some sort of a procedure, or I am not sure about that RCT and silver filling or what do you can say, like, there are multiple procedures. I am not aware about that.
So when blood splash is anticipated,
you can have a face shield.
Face shield, and does wearing 2 gloves make
no,
sense?
No, that doesn't make any difference. That doesn't make any difference.
That's a myth in the
so mask, specs, and if you have the face shield, which you are comfortable with.
Correct.
Otherwise, that should not be a hurdle for doing some sort of procedures. I mean, you may not be that skillful.
Correct.
So you have to be that much comfortable while doing, because every surgeon has to be comfortable while doing the surgery. Because you are dealing with on a live person.
Correct.
It is not some sort of a nut bolt which has been
of a car, right? Like
servicing a car, car servicing or something like that.
On the other hand, doctor, when the doctors are so well prepared, right? So there are 2 doctors categories. One who do not deal with this, right? the one who are ready to treat the patients and do whatever the procedures are required, and they have to equip themselves with so much of PPE and other elements, they would be definitely charging more to such patients for the
Absolutely,
treatment.
absolutely. You can
Have
say
you
1.5% higher.
more, right?
means डेढ़ पट बोलते हैं उसको.
Feed but more, right? Have you seen a pattern of patients being comfortable giving
Yeah,
that? There's
yeah.
no problem in that.
Basically, here comes the physician's role.
Correct.
Physician may how to make them comfortable. Like so, you are having this problem. So naturally, the doctor has to take extra precautions like Z kit they have to use. Not only for the doctors,
For the
the
staff.
staff as well.
Correct.
The one who is going to operate or the
Yes.
one who is going to do some sort of a procedure in the OT like operation theatre. So you may have to bear that. And accordingly that you are, say for example, if some procedure cost somewhere around 10,000, you might be cost somewhere around 14,000 to 15,000. Likewise, so if you make them comfortable with the upcoming questions, they are if they are anticipating with that, fair enough, they will go through that.
Correct.
And they just, and if that physician's job also to make the operating surgeon as well comfortable.
Correct. Right. This way, everybody is on a win-win side.
Yeah, it's a win-win side, and that develops your interprofessionalism as well. You can see professional brotherhood as well.
Correct. Right. Very nice. Coming to the tech part now, doctor, right? What have you seen in last 1.5 decade, right? 15 years. How has tech evolved or helped as a co-pilot for us to detect? So it could be either something in diagnostics or in the treatment planning or actual treatment or post-treatment follow-up for these patients. And what are the existing technologies that you are already using it?
No, I think AI is going to play a big role. I mean, I was there in Hyderabad for a training and AIG hospital. So I got a trend there as far as the medical management of advanced diseases. So I came to know a gastroenterologist can handle 2 to 3 things, as you said, like diagnostic and therapeutic as well. So diagnostic, he is going inside, he is handling with a tumor, he is taking a biopsy, and with the AI, he can see that biopsy picture there and there only while doing that procedure, and he can come to a provisional diagnosis. So whether that tumor has to be resected properly or you have to just come up with a biopsy.
Wow, right there and then.
Right there and
while
there.
he's
So,
inside.
you can consider the time has gone shortened.
Correct.
And previously we used to have patients who are having cancer. They were having primary stage cancer, and when then they land up into the Tata Memorial or wherever the tertiary cancer, they might be in the third stage of the cancer as well. So treating them at that point in time is a bit difficult. Similarly, as you said rightly, contactless screening, AI-based tools, they have a big role to play in medical fraternity. However, they are not going to replace the procedures or something.
Absolutely.
But yes, you can screen them. Like I had that AI opportunity, I mean, privilege to have that camp at my clinic, and with that, I could guide them to a certain dentist. So, भाई यहाँ पे जाओ, उनसे मैंने बात किया, and
Correct.
you have so and so problem. Being a medical professional, I'm not more aware about the dental issues, but I can write some sort of a diagnosis. Maybe it could be a provisional, or it might be a question mark or something. But I have updated that next surgeon, dental surgeon, that he or she is having a so and so issue. So please treat. He is on the treatment. He is virologically suppressed, and you can go ahead with the treatment. So with this, the social stigma, discrimination, fear of, or you can say anxiety, that one doctor I know that he is know my status, but going to another doctor and disclosing all those factors again, that will be another kind of a nightmare for that particular patient. Going through that particular HIV mental trauma, you can say. So that can be taken care.
Right.
And that doctor is also going to be comfortable that so and so patient is coming with that doctor's prescription, that I have to be
cautious and
I can deal with them directly.
Correct.
I know your status, and then I can also make that, and that dental surgeon also can take that opportunity to make that patient comfortable.
Correct.
And that's how you can develop your rapport, and the patient will be comfortable. He will immediately give consent, and you can go away with the procedures as well.
Right.
So yeah, contactless screening
helps.
AI tools, they have a big role to play. As I said just now, there and there you can have a diagnostic properties and therapeutic properties also.
Correct, absolutely. And as a patient with any medical condition as well, not just HIV, right? It could be diabetes, it could be some cardio-related disorders, have tendency to have more intensified consequences of oral diseases. For example, a gum recession in a person without any medical history or with a medical history is different.
Yeah.
Gum receding is fast, bone damage is faster, tooth cavitating is faster, adhesion is faster, and so on and so forth. Which is why these patients require more frequent oral health screening
Visits as well.
and visit compared to person with no history at all.
Absolutely.
Now, these visits, when they are made contactless, as we had done the drive, it's comfortable for everybody, right? The doctors who is counseling the patient and the patient who is getting the screening done. Before we did a ScanO AI uh, drive for everybody, the HIV patients that are present in your clinic, how often, doctor, you used to do dental checkup camps regularly for
No,
this?
frankly speaking, I have not done a single camp as well as far as dental part is concerned. But however, I used to check each and every patient those who are having dental issues. I used to, as I said, I used to put that torch in the mouth, and then if they have some sort of a diagnosis already done, I take that opportunity to call that particular dental surgeon. So, are you comfortable operating on HIV positive individual? If not, then can you suggest me any person who is comfortable, or I may have to direct them to an institute.
Correct.
Say, as you said, like D.Y. Patil Dental
Yes.
College, or maybe Rangunwala, or wherever the dental institutes are there,
Hmm.
or the doctor who is specialized and more comfortable operating on or doing some sort of a procedures as well. So yeah,
So,
there are so many doctors in Pune. They are doing surgeries on the HIV positive individuals having dental issues.
dental issues. I'm so glad, doctor. I'm feeling very proud indeed here because of our initiation, especially from my team side,
Yeah.
where we were able to have such a drive during the HIV day and screen so many patients at once. And I see now there should be no hurdle where we want to keep every 3 monthly or 6 monthly checkup for these patients.
Absolutely.
Right?
Likewise, I used to keep PFT camp, pulmonary function test, or spirometry camps every weekly at my clinic.
Correct.
So likewise, we can go 3 monthly, or maybe, as you said, like biannually or something.
Right, right. And were there any patient comments or opinions that you want to share?
Yeah, absolutely. They are
during the screening
Yeah,
drive
absolutely,
when it
absolutely.
was done through robot or our mobile app?
Those, two guys came to me, and that I think doctor, not sure about his name, Vinith, as you
Yes.
said. So he made that patient very comfortable.
Mm.
So you have to go this and that. He has drawn everything, and Dr. Prajakta was also there, and she was more comfortable later on. So now also she is coming in contact with me, and she has done the thing in Hadapsar as well.
Dental treatment is done.
Yeah, Hadapsar.
Correct.
But we had, because she was staying away, like in somewhere around Saswad area, so Hadapsar is close by to her. Otherwise, she has to come all the way to institute. Again, I would like to share my experience in dental college as well. There was one oropathologist, I think. He was arranging my lecture of PEP for the dental students. So, if you want to break this discrimination, stigma, or you can say hurdle of HIV in our medical fraternity, even in dental fraternity as well, you have to make the dental students, or you can say PG students or UG students, more aware about the HIV, how it is spread, what are the things to be looked after, what are the precautions to be taken, how you can deal with the needle stick injury that
Correct.
dental surgeon in and out may get that. So
Yeah, I
arranging
think,
those kind of awareness campaign is also much more important.
very important. And as much as I think we cover theoretically during second year and third year and PGs during their first year, the application should be made very clear practically of how do we deal with them. And also on the other side, what all patient needs to do. I mean, how often the screening needs to happen, how often are we monitoring the patient histories, and how often are we doing particular treatment from a preventive bracket or a preventive band, as opposed to patients with no history, should also be practically implemented in
So I
colleges.
feel, as far as dental surgeons and all your dental fraternity, so I came to read. I came across with one sentence that lips and teeth increase your face value. So if you are dealing with that,
Correct.
you have to be more cautious.
Yes.
And I'm sure you are the guys. You can, like, you might be aware of the cosmetics.
Yes.
As far as lips and dentals are concerned, forget about your eyes and overall face. But whatever the face value you have to have, that should be with the lips and teeth
Teeth.
only. Means overall looking in a cosmetic way and how you talk.
Correct.
So that is more important as far as
Right.
for the doctor fraternity, medical fraternity, even for the common public as well.
Right. Right. Absolutely, doctor. And I think more AI tools should be coming in built for either of these diagnostics or therapeutics. The way you gave the gastro example.
Yeah.
Similarly, for other elements that we have, in order to co-pilot with doctors and to shorten the time during diagnostics and surgery as we speak. Yeah.
So definitely that will fast track the treatment part basically.
Doctor, you are a member of HIV Member Association in India, right? And also an active part in IMA. How do these affiliation help? What kind of drives are they doing from their sides? And what message would you like to give to the audience on that?
Yeah, these medical communities along with this IMA and these institutes, or you can say organizations, uh, you can arrange your lectures so to break down the myths and fears in medical fraternity, or you can say medical community as well. So recently on Saturday only I had a lecture in a dermato-rheumatology conference which was arranged in Mumbai by IMA. So I took that opportunity to aware them about the HIV treatment and how to diagnose. I mean, of course, everyone is from the MBBS background, so diagnostic and therapeutic purpose. Yeah, definitely those organizations are really much more important. Even we have our local organization. Like I work in Vishnanpadi, so that comes as a Lohgaon Doctors Association. If I am working in Eroda, then Eroda Doctors Association. Go through or some like pocket kind of a small associations and organizations, and maybe you can have a roundtable discussion as well. So we have some cricket community in medical practitioners. We have some foundation which is a young doctors league, and we used to play cricket, volleyball, or maybe football. So there also we used to arrange academic parts, academic sessions. So that point in time also you can take the opportunity and to make like educate and propagate the knowledge what you have, and that can be tackled with the, as far as the HIV part is concerned. And you can with that same you can increase the advocacy, and you can continue with the reducing the stigma and discrimination as far as the uh, medical doctors, whichever the pathy they are coming from, and that will ultimately help their patients. So it's going to be a patient centric approach.
Correct.
So, and of course, if you are indulging with multiple specialties, it is going to have a professional brotherhood, interprofessionalism as well, and that keeps you a bonded person with different specialties. Like a dental surgeon is attached to a medical, chest physician, or maybe vice versa.
Correct.
Other pathies as well. As far as this advocacy is concerned, yes, I want to take a opportunity on this platform that recently in 2024 WHO come up with a new theme every yearly for HIV and AIDS. So they have a come this time that rights to what you can say, rights for the health, or rights to health.
Rights to health.
Rights to health means everyone who is an individual has a right for the health, and everyone who has an individual with a health, they have to overcome the inequalities what we were talking about. Correct. The social taboo, then stigma and discrimination. So everyone has a right to have a good health, and how you are going to achieve that good health with the help of overcoming the inequalities.
Correct.
If someone is having some sort of a problem, you have to at least guide them properly.
Correct.
And you have to make them comfortable. You have to be that those guys should be socially accepted. So this is my message to everyone, and don't treat as a HIV as a taboo or maybe a stigma. Yes, come to their platform, have a one-to-one dialogue, and make them comfortable, and they can be
treated well.
Treated well, and they can have their longer, healthy, and mentally stable life.
Correct. Yes.
Because with the advent of antiretroviral therapy, anyway they are going to live long.
Correct.
But whenever a patient lives long, those guys are dealing with comorbid conditions, or maybe any other conditions like oral problems, or maybe diabetes, hypertension. So So for those also you have to treat accordingly.
Right. Yeah. It's a very beautiful message, Dr. Milind. Thank you. That we have to suppress the inequalities. People will help make sure that as doctors, we need to make these patients comfortable. We need
Absolutely.
to come to their platform to have a one on one dialogue. And as a community or as humans in general, we need to keep away all these taboos and
Absolutely.
stigma
Absolutely.
and see everybody as one. Only then we will be able to deal with the situation and try to have not just equality but equity
Absolutely.
within our persons around us. And for fellow patients or users, audience who are on our podcast today, please make sure that you ask your fellow partner who might be high risk, as you might have listened from this, to get regular screening done. It could either be screening on ScanO, it could be getting the initial swab done from the kits that we get. Go visit doctors near you, right? We have Dr. Milind, like him, who's treating special HIV cases across the country. So go get outside your home, visit doctors, have an open communication and conversation with them, and this way we are leading to a healthier nation and a stronger nation.
Absolutely.
Yeah, yeah.
Thank you. Thanks.
Thank you for listening to today's podcast. If you like it, if you think it has added value to you, please share it, subscribe to it, and like it. Thank you so much.
Thank you.